Population Health Conference, which you may have come to back in the middle of June. And there was a really interesting conversation about the teams who'd applied for the ICS Health Inequalities money, and also the evaluative and academic prowess of KCL and other colleagues in our space. And so we started thinking that this could be quite an interesting and helpful thing to do. As we talked about it, we realised there were quite a few people who were really very interested in it from a variety of directions. But being July, there've been quite a few challenges around availability, which is why we're going to record the talk so that we are able to share it with those who are either away or at one of the other events happening today. And we're also going to be thinking about what else might be useful subsequently. So I'm going to hand over to Sean to say a couple of things, and then we'll crack on.
Cool, thanks, Sarah. I'll probably be super brief. You've covered quite a lot in your intro bit, Sarah, but just to say, I kind of think this is a bit of the start of the conversation. As you said, Sarah, there's a window of opportunity we've got, particularly with the 5.8 million that's ring-fenced to address inequalities this year, and collaboration across the partners within the ICS and KCL and HIN and others. And if we can kind of seize that window of opportunity that we've got now, that's great. But there's also, as I say, a kind of bit, I think, a opportunity for a bit more of a strategic partnership and ongoing relationship and kind of working on going forward. That's probably all I'll say. I'm looking forward to the presentations, I'm sure, as much as everyone else is.
Perfect. Thanks, Sean. So in terms of what we're the sort of running order for this afternoon, we'll start by thinking about different types of evaluation that might or might not be useful within our context, but will be useful for some of us more than others. So colleagues at King's College London, Lucilla and Ciramani are going to cover a couple of theirs. Colleagues from the HIN, the Health Innovation Network, Andrew and Ollie, are going to cover some examples of the work they've been involved with, and Kirsty and Ibby are going to cover some examples from Ask the Institute. We're going to be quite short and tight on time, with just 5 or 10 minutes per organisation. Then we'll have a quick break, because staring at a computer screen is no good for anyone for too long. Just a quick turnaround, and then we'll talk a little bit in more detail about how each of those organisations and also the Research Design Service might be able to be really helpful to you and your project. And then we'll have a Q&A and discussion at the end. In the interest of time, I suggest that we reserve all of our comments and discussion for that slot at the end. By all means, log them in the chat, and then we can, as we go, and then we can take them all together. But we'll reserve all of them and do them in one batch at the end. So I think, without further ado, I'm going to hand over to Lucilla and Ciramani to do their slot.
Sorry, I'm starting. I was waiting on Lucilla there. I thought I had a quick skim of the projects, and most of them looked like complex interventions. So I thought I would do my bit on trying to ensure there's some emphasis on understanding the complexity of context. The left picture is a community market in Kenya. Can anyone guess what the right picture is?
Brixton.
Nice East Street Market. Good try. Okay, next slide, please. You could, Sarah, you do. So I'm going to draw. That's right. I'm going to draw on 2 studies, really, both of which are alive. Hekima in Kenya. Can the creation of public health kiosks in community markets managed by nurses and community health workers improve the prevention and control of cardiovascular disease? And the Belong study, which has just started in London, could hairdressers and beauty therapists in ethnically diverse and deprived areas partner with local GP services to promote the uptake of the NHS checks? And we've just had another study pegged to this in relation to breast cancer. Click, please. So both of these are feasibility studies, and my understanding, I missed the last meeting from Lucilla, is that most of these studies will be sort of exploratory or feasibility studies. So both have in common here an emphasis on understanding how the complexity of context affects the implementation strategies and outcomes. Next slide, please. So all of our feasibility studies tend to use this phased approach. So first of all, we would do some stakeholder analysis using a standardized method to identify those who would benefit, who would be implementing, influencing, and so on. Lots of partnership building going on here. We also work with the stakeholders then to map out the community assets, which are really important when you think of complex interventions with communities and so on. We also assess whether the organizations are prepared to deliver such an intervention. And with the stakeholders, we would then do some concept mapping and co-develop a logic model, which is like a theory of change. We then would do a lot of intervention modeling, which is whether it's, examples in relation to retention, training, recruiting, and so on, of implementers and community advocates, and also refining the intervention content. Even though most of these studies are about evidence-based interventions, one still has to adapt it to be culturally appropriate. And then final phase, we do a bit of live mixed method evaluation, typically with sort of comparator group design. Next phase, next slide, please. So I thought I'd show you this because this is the Belong study where we used the Lambert DataNet. I don't know if all of you know this, it's 42 GP surgeries subscribed to it, and we were able to get all the health data from there. We used lots of ecological indices such as the index of multiple deprivation, ethnic densities, and also the online information on salons. And then we were able to create these GP surgeries salon clusters targeting areas of high need. Next slide. Sounds awful saying next slide. It takes me back to the 90s or something. So I thought I'd show you this on concept mapping. I think it's a really nice way of engaging stakeholders, especially rather reluctant ones. Here, this is the concept mapping with GP staff. And it's really nice because on the right in red, you see what they identified as the most important and feasible actions. We call it the go zone, and not surprising, training of therapists, establishing a referral pathway, a really tricky issue wherever you are in the world. Time constraints, confidentiality, stigma, and so on. Next click, please. What it does also is to identify the sort of things which it's quite surprising. Sorry, if you just go back. GPs or nurses might think it's not important or not feasible, but actually something that's very important to delivery of the project, the use of technology, for example, in the left-hand corner. Next slide. So the type of methods we use is a range, a combination. We rarely use one method. Ethnographic observations, pre-post quantitative and qualitative surveys, fidelity logs, which we train the implementers to use, visual material, very impactful, and people engage with it as well, and diaries. We also use social media to support implementers, but also evaluators. And all of this then lends to an ability to do live tracking of implementation strategies and outcomes, and then an iteration because they are feasibility studies. My last slide, please, Sarah. I thought I'd include this slide because I noticed that somewhere in some of the notes that someone wanted papers on evaluation. So the CC is the most recent, and I would say a very good framework for using for ensuring there's a very strong emphasis on understanding the context and how it affects your implementation strategies and outcomes before you think of scaling up. Recently, what we've done with this is to use it to develop case study analysis. And so Jamie Murdoch in our department is the expert on this. There are other implementation evaluation frameworks, of course, but I thought I'd mention this. Over to Lisela.
Thank you, Saromini. So I'm going to just talk about one study, which I hope will be quite useful. So I work in pregnancy, women and children's health, and I also work in prevention of childhood obesity, but this is partly what this study is about. But we, some years ago, were funded by the NIHR to undertake a lifestyle intervention in pregnant women who had a BMI of over 30. So obviously this is a common problem to all primary care practitioners, that obesity and pregnancy is one of our biggest problems. It is our actually most prevalent problem in pregnancy now. And the problem being that women who are obese when they're pregnant have an increased incidence of gestational diabetes, which is why it's been escalating in recent years. They have a higher prevalence of preeclampsia. They have more problems at delivery, have more stillbirths percentage population. So the complications of obesity and pregnancy are very substantial, and they cost the NHS a lot of money. And there's been a huge effort in the last 10 years across the world to try and develop lifestyle interventions which are likely or hopefully will improve clinical outcomes in pregnant women. Now, this Upbeat study was the basis of the intervention which has been adopted in LEAP in Lambeth, and was carried out partly in hospital setting and also partly in the community. But I just thought I might take you through the various stages of it. We understood at the time of developing this intervention that asking people to consume a diet which was a low glycemic index diet, one which has got relatively few free sugars, more complex starches, the sort of diet that you ask pregnant women to go on to when they have gestational diabetes. It had been shown that right from the beginning of pregnancy, this is likely to improve, reduce the risk of macrosomia, to improve clinical outcomes. So that was one element of the intervention, but it had never really been properly tried and tested. Another was to increase physical activity, and another was to deliver that intervention face-to-face with health trainers. So all these elements were, in different studies, shown to have been likely to work in some way, prevent gestational weight gain, and so on. But what we're wanting to do is to put this together in a complex intervention, which Saromini has just been telling us about, many different elements of it, to see whether it would improve clinical outcomes. And this was a study which was done across the United Kingdom, Manchester, Newcastle, 2 centres in London, and all in inner city populations, all with a multi-ethnic population. So this was all new. Nobody had ever really done a complex intervention like this before anywhere. So we spent a year trying to put this intervention together. So that was what Saromini is talking about. We talked to the stakeholders, we talked to the women, but most importantly, we talked to psychologists, we talked to nutritionists, we talked to health trainers, and we had a physical activity expert on the team as well. And it took us a year to put together this intervention, which we thought had a good chance of working. So we were funded by the NIHR, first of all, to do this first study, which was a process evaluation of a pilot study, a feasibility study, basically, to see whether we'd got it right. So in order to look at the change in clinical outcomes like gestational diabetes, you have to have a population of about 1,500 women to be able to adequately rely on the results statistically. So to embark upon a study at that size without doing a feasibility study would be deemed to be reckless these days. So that's what everybody does. We now, as Saromini says, we do feasibility studies when we're developing complex interventions. So the way to do this really is to use a much smaller, recruit a much smaller group of women and see whether the intervention you are recommending actually changes the behaviors that you want to change, because you're not going to change clinical outcomes like diabetes or macrosomia unless you've actually changed the diet or increased physical activity or assess whether women are happy to do it. I mean, we didn't know that, whether our population in the inner city settings that we were working in, whether they would actually be interested in doing this. And this is just the sort of thing, and quite a few of the studies which I think you'll suggesting in Southeast London are along these lines, you know, to see whether delivery of a lifestyle intervention by certain healthcare workers in a certain setting, whether it be in the community or healthy start children's Sure Start centres or wherever, whether it's going to work. And quite a few of them, I think, are along these lines. So I thought I'd just go through what we measured to see whether it was likely whether this was ever going to work. So could I have the next slide, please? So what were the questions we asked? So this wasn't in 1,500 women. This study was in a total of 89 plus 94, which was supposed to be about 16, what is that, 170 women or so. So first of all, did the intervention change the lifestyle behaviours we wanted to change? So did it change maternal diet? So the intervention was delivered by health trainers in sessions which were generally one-to-one. Sometimes we had small groups, and there were 8 sessions, one after the other, once a week. And there was evidence-based behind this, having been shown to change maternal behaviours. And the way we did it was to ask them to choose a different goal every week. So the first week they might choose to improve their physical activity by increasing their step counts. The second week they might try to improve their diet by reducing the number of free sugars or sugary drinks they were drinking. So it was all step by step, using SMART goals, as we call them, one step at a time. So that's what we did. So we recruited these ladies across the UK in the different centres, and we measured their diet. So the first question is, how do you measure diet? That is a nightmare too. So we did it by a standardised questionnaire, and this is where the evidence base is very important. If you think you're going to ask people to change their diets, you have to use a validated questionnaire, and there are some. So that's what we did. And then how did we measure physical activity? Well, we did it in 2 ways. In this study, we actually not only used a questionnaire, but we asked women to wear an accelerometer, which you can get now very cheaply. They were much more expensive in those days, which accurately measures physical activity. So we showed very nicely that this study did change maternal diet quite significantly, using a validated questionnaire. And the women also did respond to increasing physical activity. But that wasn't very much. I mean, they didn't increase it very much at all. But at least it seemed to work on that front. And every element of the diet that we looked at, whether it was free sugars or complex or a saturated fat, everything changed in the right direction. So that was very heartening. But that involved a lot of work and talking to the ladies when they came to the antenatal lifestyle classes. So it involved quite a lot of people and quite a lot of money, as you can imagine. So physical activity was interesting. You know, using the accelerometers, it was much more accurate, I think, than the physical activity questionnaire. And so going forward, we would always want to use accelerometers. So we also asked the ladies whether they thought the intervention improved the quality of life, and there are again validated questionnaires. Were things better for them? Did they feel it was doing them any good? And yes, there was some evidence that people thought it was a good idea. And then the way we were delivering the intervention, which was largely in a hospital setting in those days, which we wouldn't do again, I don't think. What were the barriers to changing those behaviours? So obviously some of them found it difficult to get to the centres. We tried to make, in the main study, we tried to make them more accessible, and we went into the community in part. So that was a very useful activity to actually speak to the pregnant women and find out how they thought and where we thought they should deliver the intervention. And did they understand the perceived benefits of it? And this was, again, you know, to understand about the problems of having a BMI of over 30 in pregnancy. Actually, most people had no idea at all that this was a potential danger to either them or their children. So we carefully described the potential problems, and then we asked the women about the perceived benefits, and they understood, and they were very keen on the whole to take part. So we showed that the intervention worked in terms of changing behaviours. We showed that we thought it would improve quality of life and so on. So we also undertook what we call the process evaluation of the study, which was an extension of all of that. Was it possible to recruit women, pregnant women, to this study in inner city populations? So would they turn up? Would they agree to come? Would they be happy to go through the 8 weeks of the study? So I won't go through all of these, but this is just common sense if you want to see whether something is likely to work. You know, at the time there was a lot of information on the internet and social media about behavioural change and in pregnancy, not necessarily the same intervention as we were suggesting, but would that sort of media, terrific media activity, would that influence their behavioural change and so on? So we actually asked people about their current knowledge, and we concluded that that wouldn't be a problem. And was the mode of delivery of the intervention acceptable? So we asked ladies questions about that. And this we did through qualitative research, through what we call semi-structured interviews. And this is a standard way of finding out what people think about it. And then the women we recruited, were they representative of the population? Well, that's very important. If anything's going to be generalizable, you need to capture the ethnic diversity of the population. And actually, the ladies who said they would like to take part were indeed, and took part, were indeed representative of the general ethnic mix of the population. And then would they attend the sessions, and would their fallout of sessions influence the dose of the intervention? That is, would they really get the whole intervention? And some women didn't attend all of them. So when we did the main trial, we introduced telephone and text messaging as an option when people couldn't turn up. But mostly the attendance was actually very good when we did the main trial. And then the fidelity, was the intervention faithfully delivered by the trial staff? So we assessed that. Were they actually providing the information for the participants in the way that was intended? So this might seem incredibly tedious, and it took us about a year and a half to do this. But this is the sort of, unless you do feasibility studies in some depth and find out about the context, and as Sir Romany said, you know, you might need to change the intervention. You generally do to line up with the context that you are delivering it in. It will only be likely to work if you do these very important preliminary investigations. And I hope that some of you who are thinking of doing lifestyle interventions, we'd be very happy to talk to you about how you might try to evaluate what will be the simplest measures that you could do to evaluate the study before you move into a major intervention, which costs probably millions. This would cost about 100,000. So that's the difference.
Thank you so much, Lisa and Sir Romany. That was extremely helpful and brilliant to see the depth of that and see that in more detail. Andrew from the HIN, I think we're on to you next, and you've got 10 minutes, so we're going to be slightly over time before we have our break, but I think it's important to give you sufficient time. So your 10 minutes starts now. Fire away.
Thanks, Sarah. And I'm joined today by HIN colleagues Ollie Brady and Kate Rawlins. So what we're going to do is we're going to give you 3 different types of rapid pragmatic evaluation that we've each individually worked on, or even maybe might call them kind of evidence generation rather than formal evaluation. And one starting kind of on the more slightly larger, more expensive side, going down to very small evaluation. So if we move on to the first slide, please. So this is a live project that we're just in the final stages of reporting on. It's looking at the introduction of E-Triage into Iapt services. To try to improve access, particularly thinking about streamlining the administrative aspect of triage within Iapt. Colleagues in London have developed an E-Triage system, and that E-Triage system was piloted within a single service within London over the last 12 months, or just shy of the last 12 months. And what they wanted to do was do a rapid pragmatic evaluation of the feasibility and acceptability of E-Triage within Iapt services. So if we move on to the next slide, please. Oh, rogue slide there. So if we carry on to the next one. There we go. So here we just wanted to pull out the type of methods that we use to answer that type of question. So it was a prospective mixed methods service evaluation, which was underpinned by an implementation framework. As an HSN, a lot of our work is thinking about spread and adoption. So we looked at quant data. So we pulled data for just over 3,000 patients from a form that was being used as part of the E-Triage process, which was being administered by LCSU. And we also pulled data from the electronic patient records of the Iapt service to look at different type of data, sort of activity around the online form, and then electronic patient record data around demographics, who were the type of people using the service, and information about patient-reported outcomes. We did two types of survey with patients to understand their experience of using the service, and also with staff to understand their perceptions of E-Triage. And then we did a deeper dive into understanding those two stakeholders' perceptions through qualitative work. So some semi-structured interviews with service users, and then a focus group with Iapt staff to really understand more about the impact of the new E-Triage system on clinical services and clinical practice. So if we move on to the next slide, so just some sort of key considerations doing this type of work. I think there's a real bonus to using routine quant data because someone's already done the hard work of the primary data collection, but there are some real issues around accessing data. It can be very time consuming. There are issues around quality and the volume of those data, because it's largely out of your control, because it's routinely collected, and some real sort of planning around the data templates that you need to extract those data, because there's always hidden things lurking within these systems when you pull off those data. And sure, as you're all aware, when you're doing qualitative and survey work, the real challenges around engaging with both staff and service users. So really thinking hard about how to incentivize both staff and also service users to engage, protecting time for staff to do and engage with field work, and also sort of thinking about reimbursing or remunerating members of the public or patients for their involvement. And I think a key limitation always for us is around how to access those more disengaged or typically excluded groups from this type of work. And then a limitation with always pragmatic rapid evaluation is trying to find some kind of a comparison to understand and interpret the findings from this type of work. So I'll now hand over to Kate, who'll talk about our work on UN Type 2 at home.
Thanks, Andrew. Hi, so I'm Kate Rawlings. I'm one of the project managers here at the Health Innovation Network in the diabetes team. So the evaluation I'm going to talk to you about is the UN Type 2 at home project. So this was a pathway where we used remote monitoring and testing technologies to let people do their annual diabetes review at home. So we posted people blood pressure machines, finger stick blood testing kits, and urine testing kits. And the main aims of this project were, firstly, to design and implement a fully remote end-to-end pathway for UN Type 2. It was also to then determine what the profile of service users were that would engage with this kind of remote pathway. And then finally, to understand about the acceptability and experience of using this pathway for both patients and staff. Next slide, please. So in terms of how we evaluated this in the project, so we took a mixed methods approach to do this. So we used data that was extracted from the two participating GP practices. So this was straight off EMIS, and that gave us an overview of the demographic information and some of the clinical information about all of the participants and also patients at that practice. We also sent out a participant survey, which 21 people completed. And then we conducted semi-structured interviews with staff and patients. And in the end, we had 7 staff members and 4 patients speak to us. And then we thematically analysed these interviews. And so the table on the right of your screen, I'm not going to take you through it, but that's on the left-hand column, it explains what our evaluation objectives were of the project, and then how we were going to measure that, and then what data we used in order to measure that. So you can see that the mixed methods, we used different types of data to for different types of measures as well. So there's an overlapping of lots of the different evaluation objectives were met using different aspects and data sources. Next slide, please. And so this is a few key considerations, and I've very much framed this as if you were commissioning an evaluation a little bit more than rather conducting it, although the points are relevant for both, about what you might want to think about if you were looking to do a mixed methods evaluation for this sort of project. So thinking at the design stage, you want to make sure that if you design in being able to capture all the information you need for the evaluation. So for example, if you need to understand reasons for non-engagement with a project or pathway, to make sure that there is a way to capture this in the operational delivery, because it's a lot harder to get that information after the fact. Also, you need to think about the size of the intervention and how many people you will need to engage with to create a meaningful evaluation. So this project you saw on the last slide had 21 survey responses and just over 10 interviews. There were only 144 service users in this project, so it's quite a small project. If you were going to be doing a much bigger project, you would need a much larger group of people that you'd be getting feedback from. Then at the data collection stage, you need to consider about how many places you're trying to get data from. It's not just the amount of data, but the amount of organizations you need to engage with. So this project, I was only working with 2 GP practices in order to access their data. The more places you're trying to access data from, the longer this tends to take, just because it slows down processes slightly. Also thinking about with interviews, they take quite a long time to do them, to write them up, to analyze them. But the good thing about interviews is they can provide really rich findings from quite a small number. So I think one thing to bear in mind is don't think you have to do loads of interviews to be able to get meaningful data. You can do a few in a specific way, but just be aware that they do take quite a lot of time. And then also thinking about recruitment bias. So as always, you're more likely to get the most engaged participants willing to come and complete surveys and interviews, depending on what the focus for your evaluation is. That might be fine. But if you're trying to understand reasons for non-compliance or non-engagement, actually only being able to speak to people that are most engaged is not really going to help you get to the bottom of what your evaluation was looking at. And then finally, other considerations of the analysis stage. So a mixed methods approach uses quantitative and qualitative analysis, and these are very separate skill sets. So if you are either completing this evaluation in-house or commissioning someone to do it, you need to make sure that those skill sets are both within the team, and it's not a given that because one person can do one type of evaluation, they'll necessarily be able to do the other. And then finally, if you are looking to include qualitative analysis as part of your evaluation, mostly this uses a theoretical framework to interpret findings. If you have one in mind before you start doing evaluation, talk to your evaluation team about this. So something, for example, probably relevant to this network being about health equity, something like the social determinants of health model. If you were one of your evaluation aims is to look at health equity, then you're probably going to want to use a theoretical framework that draws upon that. Have that discussion early on with your evaluation team so they understand what's the underpinning that you're trying to find here. Thank you. I think I'm passing on to Ollie now.
Yeah, hi everyone. Ollie Brady, I'm the Programme Director at the Health Innovation Network who covers cardiovascules among other things. And so I'm just going to give you a kind of super light touch example of how we've approached really measuring a project. I would hesitate to call it an evaluation. So we started a fellowship working with people in primary care to give them skills around CVD prevention this year, and we were a bit surprised by the response we got, and we had 106 people from across South London wanting to join the programme. And so we sort of, in order to have the maximum spread of what we were doing, we expanded it at quite short notice, but that left us with a challenge. Firstly, it was a programme that we'd started relatively rapidly and without a funding source, so we didn't have a big budget for evaluation, and we hadn't given it a lot of thought, if we're perfectly honest, about at the start of the project. And also because we were working with clinicians, working on frontline services, it's quite difficult for them to devote a lot of time. And finally, the scale, having 100 different projects meant kind of creating anything useful out of that without a huge amount of resource was going to be quite difficult. So we took a really light touch approach, and so part of the program was around introducing QI skills and approaching QI projects or quality improvement projects within the practices of the fellows, and these are quite small scale projects. And so what we did was we created a template for them to kind of track the progress and state the aims of their projects. So if you move us on to the next slide, please, Sarah. I've just got an example of what that template looks like. So simply capturing what the problem the fellow was trying to solve. This is a real example from one of the fellows in Lambeth, what their target group was, what the baseline state was of that in their practice, and what they're aiming to achieve. And then each month we're asking them to essentially capture any improvement against that baseline data, and also any learning or reflections that they've got in practice. So hopefully it's a relatively quick process each month for them to calculate where they are against their baseline, and then pop in any reflections with an aim that they can iterate against their projects as they go. So if you just pop me onto the next slide, please, Sarah. So yeah, I think it's quite a useful practical solution for us, given the problem we had around scale. And what it will help us do is identify areas for further case studies. So where we've got these templates completed by hopefully most of our 100 fellows, where there's some particularly interesting examples which are showing quite exceptional results or interesting insights from their reflections, we can then potentially do further work with those sites to undertake a deeper evaluation of what's gone on. It's quick to do and uses less resource than what we've discussed. I mean, we're probably talking about a few days' time here, rather than the sort of tens of thousands of pounds you'd probably be spending on some of the other evaluations that we've heard described. And little specialist knowledge is required to kind of use this kind of approach, but it doesn't capture a lot of what you would want, particularly patient experience of care. We're not really factoring that into the template, and it's really, in order to sort of support anything for further adoption spread, we would probably need to invest further in evaluation on some of the approaches that look promising from this approach.
That was fantastic, thank you. You can hear my printer whirring away at one of the papers that someone's mentioned that I thought I would just like a deeper look at. Really, really helpful. Thank you, colleagues at the HIN, that was fantastic. And now we are on to Ask the Institute, and I think Kirsty is going to be taking us through this. Hello, Kirsty.
Hi, Sarah, thank you. Okay, so our remit in giving some case studies on evaluation was for something a little bit more basic, perhaps. I think quick and cheap were the words that were used. So that's definitely where we're starting. And the two examples that I've got are both from clinical settings within South East London, so hopefully directly relevant. This first one is an evaluation of a training programme in a clinical setting. So this was a clinical team working within GSTT who wanted to instigate a programme of training, so in situ simulation training for their team. They have a multidisciplinary team, and they put together a training package which consisted of 19 training sessions. They very admirably were keen to know whether that training had any sort of impact on service delivery or the attitudes and competencies of their staff. So they did a very simple pre and post session questionnaire. Exactly the same questionnaire was handed out to the team before the training session started, and then on completion of their final training session. And again, similarly to all the other examples we've heard, the evaluation approach was both quantitative and qualitative, and that's probably a big take home from today. From the quantitative perspective, they had 86 participants. All their questionnaire, most of their questionnaire answers were rankings. So people were asked to rank their competencies and abilities in various areas on a scale of 1 to 10. And so they generated mean scores before and after. I could do a very simple, you know, this was the situation beforehand, this was the situation after. Really straightforward. And then from a qualitative aspect, those questionnaires also included some free text answers. And so they were able to do a nice sort of thematic analysis there, picking out some themes that they deemed most useful. I think communication, teamwork, and then some specific clinical knowledge. And that really was a process of reading and grouping and regrouping. And what the team managed to achieve was you know, a really nice outcome evaluation, most of which they did in-house. We, as the Institute, supported them with a little bit of organisation of their data, a little bit of very basic stats, but actually other than that, they did it all themselves. And I think, you know, that is the really key bit. Here, they were still able to do a meaningful evaluation with minimal resources. Next slide, Sarah. Sorry, I was trying to figure out where to press, but that's not my job. Thank you. So this next one was a clinical effectiveness evaluation in Southwark. So based on the quality improvement programme in general practice, so 2017 to 20, and it was a more complex intervention. But I'm using it here because it's so relevant to the population that we're talking about. So within that complex intervention, there were 6 health conditions targeted for improvement. There were local clinic guides drawn up, EMIS templates and decision-making tools, educational events, and there was analyst support in the GP practices. And again, qualitative and quantitative analysis and evaluation, which is so important to get an all-rounded approach of these interventions. So from a qualitative point of view, there was ethnographic observation, key informant interviews, and focus group discussions. And from a quantitative point of view, there was, again, a survey of primary care clinicians, quality and outcomes framework and data analysis, so Southwark versus the rest of London. And there were EMIS records from 40 practices. So we could look at template use and an interrupted time series analysis, which is just a fancy way of looking at trends, or looking at trends before the intervention and after, and getting an idea of how those trends have been changed by those interventions. So a more complex evaluation and a more expensive one, I think the ballpark was around 100,000, which I think is similar to the one Lucilla quoted. So that's obviously a popular amount for that kind of evaluation. But again, something being you know, done very locally in South East London, and a good example to take forward. Thanks, Sarah.
That was fantastic, thank you. And I love the example that was possible to do something really, really meaningful with minimal resource, and then also right through to that stretch, to that more expensive one. Really, really fantastic. Thank you to everybody who's presented those ideas. We're going to have a really quick comfort break now. We'll keep it just to 5 minutes so that we've got enough time to have some proper Q&A at the end. Feel free to change your camera and your mic, etc. So we'll come right back at 20 past for a little bit more from the presenters. 20 past has come round quickly. We'll make a start again rather soon. Okay, I think we're ready to go. So what we're going to do now is each of the organisations, along with Peter Lavelle from the Research Design Service, is just going to talk quickly about how their organisation can support you. Now, we had said 5 minutes each, but given that it's only 8 minutes before we were hoping to go for discussion, I'm going to set a challenge of 2 minutes per organisation. Is that possible? I don't know. I might be rogue and put 2 minutes in the chat when each organisation is done. But it's really important we do get some time for conversations. So I think first off, that's not on slide sharing properly. In fact, I'm not going to share until we get to Kirsty, because Sirimani and Lucilla don't have slides. So I'll hand right over to you if you're there, Lucilla or Sirimani.
I'm here, it's Lucilla.
Great.
So I'll just put my camera on. That's most of the 2 minutes now. Sirimani, are you still there? Yes. Do you want to kick off? I think because Sirimani is really the intervention evaluation expert as opposed to myself. Carry on, and I'll mention one or two others perhaps. Sirimani.
Sorry, Sarah. So this was how we can help. That's right. Yes, 2 minutes starting now. Right. Well, we have several experts here in relation to sampling, to implementation theory and evaluation, economics evaluation, and so on. So I guess we are able to offer sort of advisory support. Possibly at the outset. I would say most people would want that instead of during it. So Lucilla and I kind of discussed this to say that we'd probably be able to have some guidance, guide you into it. I'm not sure we've got the resources to actually do any of the stuff for you, but to guide you through to ensure that the evidence the information you collect be rigorous enough for your, the further study, to inform a further study. Is that helpful?
Very helpful.
I mean,
thank you.
You can contact myself or Sirimani or myself, but just to help with the variables that maybe should be collected for a given intervention, we suggested we might have half-hour Teams chats with anybody who might like to be interested. And if it's not ourselves, we might find somebody else who'd be very appropriate for a given intervention. So just a quickie to describe the intervention and help about the variables to be collected and any quick evaluation.
That's fantastic. Really helpful. Thank you. Kirsty.
Thanks, Sarah. I did have a couple of slides which maybe are redundant given the time frame, but let's whiz through them. If you can go back one, that would be helpful. Thanks. So in this context, we are Women and Children's at King's Health Partners, and as part of that, we run a responsive advisory service called Ask the Institute, which does a couple of things, but most relevant to this conversation is that we provide pragmatic support to increase the use of academically rigorous methods. Thank you. Next slide. And thanks. And this is our overall approach. So we split our offer, if you like, into 4 quadrants, and those are knowledge and understanding, design, implementation and evaluation. And in each of these, I've given just a few examples of what that means. So that might mean evidence reviews at the sort of knowledge and understanding end, or that might mean a full service and policy evaluation at the other end. If we go to the next slide, then I can just tell you a little bit about the different levels of input that we have, all of which obviously come with varying levels of resource input for us. But they stem from the advice level, so discrete one-off pieces of work, answering very simple, straightforward questions at the design stage, perhaps, and guidance about how and where to retrieve information, or maybe a brief peer review of an article or report. There's a lot of examples within each one. Next step up would be support, maybe ongoing support of a research proposal or funding bid, maybe helping the development of that ethics process. Also some professional support, costings for things, the sort of basics, and a more detailed peer review of reports and articles. And then the sort of upper level of what we offer is actual research. So maybe doing a rapid review or a systematic review on a particular topic, or collecting and analysing that data ourselves on an area that we've been asked to. I think there's one more slide, Sarah, which is just a shout out to the team. We're sort of varying expertise that works together, and some contact details. So please do, if any of that sounds useful for current projects or future ones. Thank you. That was longer than 2 minutes. Sorry.
But only just.
Can I take 2 seconds to just plug the Ask the Institute query form, which is in the chat. So if you have a query related to your evaluation, you can just submit it on the form.
Thank you. Perfect and wonderfully brief. Okay, Andrew from the HIN, you might hear my timer in the background.
The pressure is on.
I know.
So as an HSN, our interest is particularly in spread and adoption. And we sit more on the pragmatic, rapid evaluation end of the spectrum rather than doing research. So if you're interested in research, then I would suggest sort of other partners are more appropriate. So we have a team of experienced analysts, data analysts, mixed methods researchers, but also because we're an academic health science network, we have sort of senior health and care managers, people with clinical backgrounds, as well as specialists in technology and innovation. So we can combine that all together to support with sort of bespoke commissioned evaluation and informatics support. If we need extra input, specialist input such as health economics, statistics, data science, through our kind of partners, we can also access that as well. And most of our support would be fee for service, although like many others, we're happy to have sort of discrete one-off conversation as part of thinking through projects. But similarly to others, we're here to provide advice and support around design and ongoing sort of support if you're doing it yourself. We can support with training, capacity building. We've done that by ourselves and with our colleagues in the Applied Research Collaboration, and then delivery of mixed methods evaluations, whether it's new products, services, pathways, particularly innovation, implementation, scale up, and a real kind of interest around digital health technology within kind of real world settings. So that's the HIN.
Fantastic. That was 20 seconds under. Very good job. And now, last but by no means least, Peter from the Research Design Service.
Thank you. Can you share my slides?
I can't because they're in PDF and I just can't. Okay. Oh, actually, I know what I could do. Yep, sorry, carry on and I will.
That's fine. So I'd just like to very quickly tell you about the RDS. The RDS is a national network of support services supporting those putting together funding applications, either for projects, programs of research, or for fellowships. There's an RDS dedicated for London. Our support is confidential and free of charge. second slide. Just to give you an insight into RDS London, we're the collaboration between the 4 large academic institutions. It's led by King's. We've divided London into 4 patches, so all of those institutions south of the river come to King's. Hang on, that's one slide. People who work for the RDS are active researchers and academics. We buy out some of their time to then consult for the RDS. Give you an idea of the size of RDS, there's 18 FTEs worth of people working for RDS with backgrounds in statistics, health economics, qualitative methods, health psychology, data science, public involvement, and most importantly, with great grant writing skills. So DHSC have set us the target to increase the volume and proportion of high quality funding applications, and we do this by providing guidance on research methods. But it's often much more than that. We can help you identify a suitable funding source, we can identify collaborators, we advocate for public involvement, we help you get the narrative right, and also if you fail first time around, we can help with resubmission. We are strong advocates for public involvement, and so we have specialist advisors in PPI, we run PPI workshops, and we have a PPI bursary for those who want to have small sums of money to do initial PPI work. Access is through the website. We deliver our support through drop-ins, through online guidance, and through one-to-one feedback. If you opt for the one-to-one option, we'll assign an advisor who will act as your case manager, give some initial feedback, and then introduce you to other members of the team as appropriate. The most important thing is come to us early, ideally several weeks, if not months ahead of your submission deadline, but certainly not less than 4 weeks, because we won't be able to help at that shortest time. So yeah, go to the website and read more about us. It's well worth it.
That's fantastic, thank you. And I will. Yeah, it was, but don't worry. I had told you 5. It was much less than that. And we've caught up some time, so thank you for whistling, giving us a whistle stop tour. We are planning to share redacted slides. I know some of them had some unpublished data, and we also will make the recording available. So Saida, we can stop recording now, I think, because we'll go to Q&A and discussion. Can I suggest that if anybody asks, whoever would like